Hello, my dear future doctors. Welcome to class. Today, we are tackling a question that you will face every single day of your professional lives.
This is the big dilemma, isn't it? It feels like a huge maze, no? But don't you worry, there is a method to this madness. And today, we are going to break it down step by step so you can make the best choice every single time.
So here is our roadmap for today's discussion. We'll start with the patient, then figure out the organism, choose the drug, and even look at why two might be better than one. We'll also cover prevention and what happens when things don't go according to plan.
Okay, let's dive right into it. The choice of an antimicrobial agent, it always boils down to three key areas of consideration. Think of it as a triangle, a simple framework to guide all your decisions. And here they are. Remember this simple framework, friends. Patient, organism, drug. This is your fundamental guide for rational prescribing. Get this in your heads. It is everything.
All right, so let's move to our first pillar, the patient. You have to remember, you are not treating a disease, you are treating a person. And that person's unique physiology is always your starting point.
Look at this list. You must always consider these factors: age, kidney function, liver function, any allergies, even their genetics. Why? Because a drug that is a cure for one patient can literally be a poison for another. It's that serious. Now, dhyan do, pay close attention, this part is very important. Age dramatically changes how a patient's body handles a drug. For a newborn, their body can't process chloramphenicol properly, leading to the dreaded gray baby syndrome. And on the other end of the spectrum, an elderly patient's kidneys might struggle to clear aminoglycosides, putting them at risk for what? Deafness. So the extremes of age demand extreme caution.
Okay, this is a very, very important chart for your exams and for your practice. The kidneys are the main exit door for so many drugs, right? So if that door is jammed even a little bit, the drugs build up and can become toxic. See here? For aminoglycosides, you have to reduce the dose even in mild failure. And some drugs like tetracyclines, just avoid them. So the bottom line is, always check renal function.
And it's a similar story with the liver. It's the body's main processing plant, no? If it's compromised, you must be cautious. It's the primary site of metabolism for many of these agents. So for some, like erythromycin estolate, you just avoid them. For others, like isoniazid or rifampin, you absolutely need to reduce the dose. Right. So now that we've considered our patient, we must identify the culprit. The bug. What is the enemy we are trying to fight? This is step 2. So how do you identify it? Well, your approach will depend on the situation. Sometimes the diagnosis is crystal clear. Think syphilis, think cholera, the signs are classic. Other times, for common infections like tonsillitis, you make an educated guess. But then, for the big, bad, unknown infections like meningitis, you must rely on bacteriological tests. No guessing there. Okay, let's talk about some key terms. First up, MIC. Minimum inhibitory concentration. The MIC tells us the minimum power we need to stop the enemy from multiplying. It's like putting the brakes on their growth. We're not killing them yet, just stopping them in their tracks. Is it clear? Inhibition. Now, the MBC, this is a different beast altogether. Minimum bactericidal concentration. This is more aggressive. It's the concentration needed to actually kill 99.9% of the bacteria. So MIC is about stopping them, MBC is about wiping them out. See the difference? And this is a really interesting idea, the post-antibiotic effect, or PAE. What's so cool about this is that some drugs keep working even after their levels in the body have dropped. It's like they hit the bacteria so hard that the bacteria are stunned for a while and can't start growing again immediately. A very useful property. Okay, we know our patient, we know our enemy. So chalo, let's select the right weapon from our arsenal. It's time to talk about the drug. Now, this slide is brilliant because it shows two totally different strategies. On one side, you have concentration-dependent killing. This is like a sniper shot. A single, powerful, high-dose hit is what matters. Aminoglycosides work like this. On the other side, you have time-dependent killing. This is more like a siege. You don't need a super high concentration, but you need to maintain pressure. Keep the drug level above the MIC for a long time. That's how our beta-lactams, like penicillin, work. Got it?
And of course, there's more. You have to weigh all these properties. What's its spectrum? Is it bacteriostatic or bactericidal? How toxic is it? And this one is key, pharmacokinetics. Can the drug even reach the site of infection? A great drug is useless if it can't get to the battlefield, right? And finally, of course, there's the cost. It's a complex decision. Okay, so sometimes one weapon is not enough, and that's when we have to think about combination therapy. Let's understand when and why we might use two drugs instead of one. We combine drugs with a very specific purpose in mind. We don't just throw two drugs at a problem hoping for the best. We do it to achieve synergism. That's when 1 + 1 = 3. We also do it to prevent resistance from developing. And sometimes, in a really sick patient with an unknown infection, we need to broaden our attack to cover all the likely suspects. But you have to be very, very careful here. Look at this table. Combining two bactericidal drugs? Often great. But see that last row? Combining a cidal and a static drug? That can be a problem. Why? Well, a bactericidal drug often works best on bacteria that are actively dividing. And a bacteriostatic drug, it stops them from dividing, so it can be counterproductive. All right, finally, let's discuss two important scenarios: how we use these drugs to prevent infection and what to do when our therapy fails.
When we talk about prevention, especially in surgery, understanding this wound classification is key. It's a scale of risk. A clean wound has very low risk, so you might not need prophylaxis. But as you go down, clean, contaminated, the risk goes up. And for a dirty wound, like an abscess, antibiotics are a must.
So, your patient is not improving. What do? Don't just change the antibiotic. First, review these common causes. Was the drug wrong? The dose? Is there an abscess that needs draining? Or, and this is a huge one, are you trying to treat a viral infection with an antibiotic? That will never work. So think, don't just react.
So, I'll leave you with this thought. You've learned the rules today. But in this age of growing resistance, the big question is, are we choosing wisely? Mastering these principles is not just about passing your exams, my friends. It is our duty in the fight against antimicrobial resistance. Every choice you make matters. So please, choose wisely.
Hello, everyone, and welcome. Today, we are going to cover a really, really important chapter. We're going to talk about the story of the first ever man-made antimicrobial drugs. These are the originals, the ones that basically changed the world of medicine. So please, pay close attention. Let's get started.
So just try to picture this for a moment. The world before 1935. A simple scratch, a sore throat, things we don't even think about today, could easily lead to a fatal infection. As a doctor, you would have almost nothing in your hands to fight these pus-forming bacteria. It must have been a terrifying time, and the whole world was just waiting for some kind of miracle.
And that miracle, that big breakthrough, well, it came in the form of our first topic today, the sulfonylamides. Now listen, these were not like penicillin, which comes from a fungus. No. These were completely created in a lab. They were synthetic, the very first effective antimicrobial agents. And they were an absolute game changer. They really kickstarted a revolution.
And the story of how they found it is, well, it's fantastic. There was a scientist, Domark, and can you guess what he was testing? Industrial dyes, the kind of stuff used to color clothes. He found that this one red dye, Prontosil, could cure mice from these deadly streptococcal infections. But here's the funny thing. The dye did nothing in a test tube. It only worked inside a living body. So what was the funda? The body itself was doing the chemistry. It was breaking down the dye and releasing the real weapon, a much simpler molecule called sulfonylamide.
So from that one little discovery, a whole family of drugs just exploded onto the scene. And we classify them based on something very simple. How long do they last in the body? So you have your short-acting ones, like sulfadiazine, intermediate-acting, like sulfamethoxazole. Now, please keep that one in mind. It's a key player later on. And then you have the long-acting ones, like sulfadoxine.
So the really big question is, how do they actually work? What is the mechanism? Well, the funda behind it is incredibly clever. It's basically a brilliant strategy of disguise and deception, all happening at the molecular level.
To understand this disguise, first you have to meet a molecule called PABA, that's short for para-aminobenzoic acid. Now for many bacteria, PABA is it's like flour for making chapatis. They absolutely need it. They use it as a building block to make their own folic acid. And if they can't make folic acid, they die. It's that simple.
And this is where the disguise comes in. Just look at this picture. See how similar sulfonamide looks to PABA? They're almost identical twins. It's the perfect imposter. So the bacteria's enzyme, the one that's supposed to grab PABA to make folic acid, gets completely fooled. It picks up the sulfonamide by mistake. But the sulfa drug, it's a fake key. It fits in the lock, but it won't turn. It just gets stuck. And the whole factory for making folic acid just grinds to a halt.
Now you might be wondering, okay, if it blocks folic acid, why doesn't it harm our own cells? Ah, this is the beautiful part. This is what we call selective toxicity. You see, bacteria have to make their own folic acid from scratch. They have no other option. But we humans, we just get it ready-made from our diet, from our leafy vegetables, our dal, our fruits. So the drug cleverly starves the bacteria while leaving us completely untouched. Isn't that brilliant?
But you know, bacteria are smart. They evolve, they learn to fight back, they develop resistance. So we had to get even smarter. And that brings us to a very clever combination drug, cotrimmoxazole. This is a perfect example of synergy in medicine. You know, where 1 + 1 equals much, much more than 2.
The strategy here is something called a sequential blockade. Think of it like a double attack on the same assembly line. First, sulfamethoxazole, the one I told you to remember, it blocks the first step where PBA gets used. Then another drug, trimethoprim, comes in and blocks the very next step in the production line. It's a 1-2 punch.
This diagram here shows it perfectly. See, PABA is supposed to become dihydrofolic acid, or DHFA. Sulfonamide blocks that. Then, any DHFA that might get made is supposed to become the final product, tetrahydrofolic acid, or THFA. Well, trimethoprim blocks that step. By hitting 2 steps one after the other, we make absolutely sure the entire production line is completely shut down. And the result of this teamwork is profound. Listen carefully. On their own, each of these drugs is usually bacteriostatic. That means they just stop the bacteria from growing. It's like putting them in jail. But when you combine them, the combination becomes bactericidal. It doesn't just put them in jail, it kills them. This is a very, very important concept to remember for your exam.
All right, let's switch gears completely. We've talked about starving bacteria. Now let's look at a totally different approach. A direct attack on the bacteria's most precious possession. It's DNA. And this brings us to our next class of drugs, the quinolones.
So the family tree here starts with nalidixic acid, back in the 1960s. It was mainly useful for UTIs and GI infections caused by gram-negative bacteria. But it wasn't perfect. It wasn't super powerful, it didn't get into the blood very well, and bacteria figured out how to resist it pretty quickly. It was a good start, but there was a lot of room for improvement.
And that big improvement, the major breakthrough, came in the 80s. Scientists did one tiny little thing. They added a single fluorine atom to the basic structure. And with that, bam, we got the fluoroquinolones like ciprofloxacin. This one small change was a huge leap forward. It made the drugs way more powerful, they could kill more types of bacteria, and it was much harder for the bacteria to fight back.
So how do they attack the DNA? Well, they target a crucial enzyme called DNA gyrase. Now, just imagine the bacterial DNA is like a very, very tightly coiled rope. To make a copy of itself, the bacteria has to unwind the rope, copy it, and then coil it back up perfectly. DNA gyrase is the machine that does all this coiling and uncoiling. Quinolones, they just go in and break that machine. The DNA gets tangled and damaged, replication stops, and the cell dies.
And just like the other drug families, this one also evolved. We have generations. The first generation fluoroquinolones, like Cipro, were masters against gram-negative bacteria. Then came the second generation, your levofloxacin, your moxifloxacin. These were upgraded. They were also very good against gram-positive bacteria, like pneumococci. This made them much more versatile weapons for us to use. Okay, everyone, let's bring this all together now. Pay attention. This next slide is the most important one. This is the high-yield summary of everything we've talked about. These are the key points you absolutely must take away for your exams. Let's do a quick rapid-fire review. First, sulfonamides. Mechanism, they block folic acid synthesis because they look like PABA. Key point, they are bacteriostatic. Next, cotrimmoxazole. Mechanism, a sequential block of that same pathway. Key takeaway, it's a synergistic combination that becomes bactericidal. And finally, fluoroquinolones. Mechanism, they inhibit DNA gyrase. And the key point, they are broad spectrum and bactericidal. Simple and clear.
You know, when you really think about it, the journey of these drugs is an amazing story of human cleverness. We started by creating a molecule that could trick and starve bacteria. And then
We figured out how to create another molecule that could go right into the cell's headquarters and just shatter its DNA. It's like we're in a constant chess game with these microbes.
And that brings us to the biggest challenge we face today. Bacteria are always evolving. Resistance is a huge, huge problem. So the question I want to leave with you is this. You are the next generation of doctors and scientists. What do you think the next chapter in this story will be? What new, clever strategy will we come up with to stay one step ahead in this critical fight? Something to think about. Thank you for your attention.